Good evening, all the aspirants present here. It's going to be an interactive session. Any doubt, any question, you can drop it in the chat box. So, the topic for today is GI, and the speaker that we have here is Dr. Deepak Gupta, sir. He is a locum consultant in ICU at Watford General Hospital, North London. So, you can start. Thank you.
Okay. Thank you, Fatima, for the introduction. First of all, apologies from my side. I was to take this class 2 weeks back, but due to some work commitments, I could not do that. So finally, we're doing this class today. So, as Fatima said, this will be a totally interactive type of class. So, I'll be posting the questions as in EDIC 1, and there will be answers. You can answer in the chat box, then we'll see what is the right answer and why is the answer correct. Okay, I'll be sharing my screen now. Yeah. So, this will be an EDIC 1 class. Uh, I'm pretty sure everybody of you must be aware regarding the pattern. What pattern is there in EDIC? How the questions are there? Just a brief overview. 100 questions will be there, out of which A type will be the single answer questions, which would be marked as 1 mark for each questions, and the rest would be K type, where there will be 4 answers and you will have to answer it at true or false. Okay. So I think every one of you who has to appear for this exam first should go through the ESICM site, just exactly go through the pattern, the type of questions they ask, how is the marking system, so that you're pretty sure exactly what you're going to face during the exam. Okay, so not wasting more time, let's start. I'll be trying to cover as many questions as possible within this hour. Few of the questions, it's not always my made questions. I've taken from various MCQ books. So if you have read few questions, you may be aware of these questions where you have read in previous MCQ books. The purpose of this class is not to learn and by heart the MCQs what I'm showing to you. This may not come. There may be separate MCQs which will be coming in the exams. Purpose of this class to make you aware regarding the pattern, how to solve the MCQs, and what are the important tips to solve this MCQ regarding EDIC. I'll try to share as the MCQs come. Okay. Any place, anytime you feel there's a problem, you need some explanation, you can just put it in chat box and I'll try to solve the problem then and there itself. Okay. So let's start. Just 1 minute. Yeah. So first I'll try to cover a few type A questions and then we'll go for type K questions. So type A, this is the first question before you. I'll read out the question. Botulinum toxin injection, esophageal pneumatic dilatation, and peroral endoscopic myotomy. Sorry, you can answer in the chat box. Sorry, am I audible?
Yes, sir, you are audible.
Okay. Okay, screen is visible?
The screen is not visible.
Oh, how did it go away? Yeah. I'll try to share it again. Just a second, okay? That is not here. Yeah, now is it visible? The screen is visible? My son.
Yes, yes, sir.
Yeah, just 1 minute. Sorry, I don't know what lapse was there. Happy together somehow. Is the screen visible now?
Yeah.
Yeah. So this was the question. Have you read this question? You can answer in the chat box. If you were to transplant your entire life to Barovia, as King Alexander's duties and travel would be immense. I think someone's mic is open and some commentary going on. Yeah. So you can answer in the chat box. See, this is just a practice. Even if you are wrong in this, don't worry about that. I don't want you to make mistakes during your actual exam. So even if you don't know, you want to guess, you can guess here. There's nothing is going to happen in this. Okay. Yeah, D. Someone has answered B. Okay. Let's see what the correct answer is. The correct answer for this would be, so it's C. C is esophageal pneumatic dilatation. So what exactly is happening in this patient? So this is a typical case of achalasia. It is a primary esophageal disorder with pathological consequences of degeneration of ganglionic cells in the mesenteric plexus of esophageal body and lower esophageal sphincter of unknown etiology. This degeneration leads to insufficient relaxation of lower esophageal sphincter. Okay, so the esophagography typically reveals the esophageal peristalsis with proximal dilatation and minimal lower esophageal opening, resulting in a bird's beak appearance. At present, achalasia is incurable and management consists of palliation of symptoms. In patients who are felt to be good surgical candidates, laparoscopic myotomy with painful fundoplication is an effective strategy for long-term resolution of symptoms. However, in patients who are high-risk surgical candidates, initial treatment with graded pneumatic dilatation is recommended. So basically, this is a case of achalasia, and they are asking you. So this they have explained what exactly achalasia is, and the first initial treatment would be graded pneumatic dilatation. So that was the answer. Ruling out the other options which were given in the question, like fundoplication. So complete 360-degree fundoplication would exacerbate the symptoms of dysphagia and is not an appropriate intervention. Okay, so this was wrong. Regarding botulinum toxin, it is an attractive and user-friendly approach which interrupts the release of acetylcholine from presynaptic vesicles, causing an interruption of neurogenic component but has no effect on the myogenic components of lower esophageal sphincter. Okay, although the initial 1 month response rate is 75%, therapeutic effect wears off in approximately 50% of the patient relapses and requires repeat treatment 6 to 24-month intervals. Okay, POEM, they have given one of the options. It is a novel method of endoluminal myotomy performed by traversing the esophageal mucosa. Also, the technique is promising. It requires advanced endoscopic skills. In addition, POAM has shown in 50% of the patients to promote further acid reflux. Okay, so first tip here is, this is a type of question, a bit of a difficult question. In critical care, in daily routine, you don't see such patients, and more of a surgical questions. But I have kept specifically this question to make you aware that such questions can come in your exam. Maybe if you're not aware, you can guess it. If these are repeat questions which are coming, you would be able to answer if you have learned and by heart such questions. Okay, so I don't expect a very critical care person to be aware of such questions, but such questions can come in the EDIC 1 exams. Next, question number 2. This is a 65-year-old woman with history of smoking and osteoarthritis recovering well after a cosmetic plastic surgery procedure. On post-op day 2, has resumed her home medications, including daily aspirin, and is being prepared for discharge. However, she becomes newly hypotensive. She is transferred to the ICU with 1 liter of normal saline infusing and a BP of 92 by 60 mm of Hg with a heart rate of 1 minute. She is pale, diaphoretic, agitated. Her incision is clean and dry. The lab results on arrival in the ICU: HB 6.5 from 12. Last checked 2 days prior. She then has an episode of hematemesis. BP drops to 70 by 40 mm of Hg. Transfusion of PRBC is initiated. Which of the following is the most appropriate next step in the management of this patient? The options are 5. This is A is stat CT angiogram of the abdomen. B, interventional radiology consultation for possible angioembolization. Urgent surgical exploration. Upper GI endoscopy. And last is PRBC transfusion to hemoglobin of more than 10 with no further intervention. Those who want to answer, they can answer in the chat box, and then we'll see a very typical scenario and a patient what you get in the ICU. This is a very typical ICU patient, and I expect most of you to answer it correctly. B, D, yeah. Anyone more? See, even if you're wrong, just go for it. At least you will remember that I had made this mistake. So when actually you go for the exam, you'll remember that. Okay. B, D, B, D. Most of you answered. So let's see what the correct answer is. B, yeah. The correct answer is D. D is, what is that D? It's upper GI endoscopy. Let's see why B is not correct and D is the correct answer. Okay. So this patient with hematemesis became hemodynamically unstable because of the upper GI bleed. Smoking, aspiration, and NSAID use are the most important risk factor for peptic ulcer disease, and in this case, the patient is likely have acutely bled from an ulcer. Up to 50% of peptic ulcers are asymptomatic until the bleeding occurs, which may present as hematemesis or melena. Upper GI endoscopy is the gold standard for the diagnosis of peptic ulcer disease and the first line therapy for bleeding ulcers. This should be performed urgently in hemodynamically unstable patient as it allows for both diagnosis and the treatment. So upper GI endoscopy has got an upper hand over all other options because it is not only diagnostic, it is also a treatment option. So with one investigation, you are able to diagnose the case also, and if the bleeding, you find the bleeder, you can do the treatment also. That is why upper GI endoscopy is the correct answer. Let's see regarding the other options. Many of them have answered B and other options also. Regarding CT angiogram of the abdomen, it may identify a source of bleeding. However, it is less sensitive than endoscopy for identifying a source of bleeding and does not allow therapeutic intervention. Okay. Regarding surgical exploration, it is associated with a higher risk of complications than endoscopic management and so should not be pursued initially. So obviously surgical we go at the last. Regarding angiographic embolization, many of you have answered this as an option. It is an alternative to repeat endoscopy or surgical intervention, but does not replace the initial endoscopic management of upper GI bleed and may have a higher risk of rebleeding than surgery. Okay, that is why endoscopy is always preferred. It's diagnostic and treatment. And the last option, transfusion of blood products is essential in early management of the patient with hypotension and evidence of bleeding. Although resuscitation goals for the acute upper GI bleeding vary, restrictive changes recommend transfusion for hemoglobin of 10 milligram per deciliter is associated with higher rates of mortality and rebleeding and therefore not recommended. This is actually now everybody knows that rather than liberal strategy, the restrictive strategy, just keeping a hemoglobin above 7 is recommended because higher hemoglobins, more bleeding occurs and it is associated with high mortalities. Okay, so the option was D in this answer. The option was correct option was endoscopy. Okay, let's move forward. Just a few of the articles you can read on net. You can get this very nice ACG clinical guideline of upper gastrointestinal and ulcer bleeding. You can read this for upper GI bleed because one of the favorite topics of EDIC 1, you may get 1 or 2 questions of upper GI bleed in your EDIC 1 exam. Okay. So next, moving forward, this is a 55-year-old male with hypertension, anxiety, type 1 diabetes, recently adjusted with medication regime and began taking clonidine. He presents with an abdominal pain and nausea. This has been associated with occasional episodes of emesis of gastric content over the past few weeks. His weight is unchanged. His vital signs are within normal limit. On physical examination, abdomen is distended with moderate tenderness in the epigastrium, but no rebound or guarding. Electrolytes are unremarkable. His finger stick glucose is 350 milligram per deciliter. Endoscopy and CT scan shows large amount of gastric content and no evidence of mechanical obstruction. In addition to reviewing his medication list, what is the best next step in the caring for this patient? So the options are nasogastric decompression, dietary modification and optimization of glycemic control, PPI treatment, percutaneous gastrostomy, tube for venting, or surgical consultation for gastrojejunostomy. You can answer in the chat box. Few of you have answered. Other can also attempt this. A, someone has answered B, and someone again has answered B. You need to know what exactly is happening in this patient, so we'll get the answer. So one important tip in this question is you need to read the last line what they are asking very clearly. In addition to reviewing his medication list, what is the best next step? Okay, they are asking the next step, not the overall best treatment. Okay, so this last line is very important. That changes the answer. So you have to be very specific with that. So let's see what the correct answer is. The correct answer is B. Most of you have got it correctly. It's the dietary modification and optimization of glycemic control. Why this is an answer? If you know what exactly is the case is, the diagnosis is gastroparesis. It is a delayed gastric emptying. It is a motility disorder in which food remains in the stomach for a prolonged period of time. This typically presents with postprandial fullness, nausea, vomiting, pain, bloating. It may be due to a variety of factors such as medication that prolong the gastric emptying, including alpha 2 adrenergic agonist. So, if you remember in the question in the second line, they have given the patient was taking clonidine. So, clonidine is an alpha 2 adrenergic agonist, which was a clue given in the second line, which has caused this gastroparesis. Okay. Other drugs are narcotics, CCBs, TCAs, incretin based diabetic medications. DM is also a risk factor for gastroparesis, with type 1 diabetes at greater risk than type 2. First line therapy is dietary modification and optimization of the glycemic control. So they have asked in the question is the best next step. So next step would be first dietary modification and optimization of glycemic control. Okay. Large meals and foods high, sorry, and foods high in fat and fiber should be avoided. Ruling out other options, in this patient there is no mechanical obstruction or no current complaints of emesis, making nasogastric decompression unnecessary. Similarly, there is no mention of ulcerative disease on the endoscopy and therefore no indication of PPIs. Gastrostomy tube is very rarely indicated in gastroparesis and certainly not in this patient with recent onset of mild symptoms who have not yet tried lifestyle or medical managements. And gastrojejunostomy may be used to bypass a mechanical gastric outlet obstruction but will not improve the motility of the stomach. Okay, so concentrate on the last line. What exactly they want? They just don't want the very specific treatment. They want what would be the next step. Okay, that changes your answer. Moving forward, now this is a 34-year-old man with a history of Crohn's disease, presents with foul smelling drainage from his abdominal wall. He has experienced malaise and poor oral intake over preceding 3 weeks and have been worsening abdominal pain for 5 days. In the last 3 days, he noticed swelling in the abdominal wall superior to umbilicus in an area that began to drain foul smelling greenish discharge. Area becomes erythematous, tender, drainage has increased in volume over the past 24 hours, which has started to develop fever, chills, dark urine. On arrival, his vitals are temperature 102, heart rate 110, BP 95/50, respiratory rate 18, saturation 98% on room air. CT shows oral contrast extravasation from the small bowel that exists in the site of drainage, but no drainable fluid collection in the abdominal wall. What is the most appropriate management at this time? Okay, again, just concentrate on the last line. They are asking the most appropriate management, not the next step or something at this time. So the options are: first, take the patient to the OR urgently for exploratory laparotomy. Start broad spectrum antibiotics. Broad spectrum monitor fluids, electrolyte status closely and nutritional support. Perform incision and drainage at the bedside. Percutaneous jejunostomy tube placement. Initiate tube feeding. consult a gastroenterology for endoscopy. Yeah, if you have already answered, anyone more wants to attempt? So if you know the diagnosis, what is happening in this patient, you can answer that correctly. Just go for it. Others also, if you, even if it is wrong, don't worry. You'll just learn something from this. Okay, let's see what exactly is the correct answer in this. It's B. Most of you answered correctly. It's we should start broad spectrum antibiotics, monitor fluids, electrolytes, and give nutritional support to this patient. Because what is the diagnosis? This patient is a case of enterocutaneous fistula. It is the patients with IBD are particularly prone for this. These often presents with a prior operation but can also appear spontaneously, particularly in patients with IBD. When patients first present with ECF, they are often volume depleted with electrolyte disarrays from intestinal losses and can have sepsis. So definitely they require broad spectrum antibiotics and drainage of any associated intra-abdominal abscesses if present. Patients should be started on TPN until the anatomy of fistula is defined and output can be controlled. The anatomy can usually be defined with a CT scan with enteral and IV contrast, which has the added benefit of defining any undrained intra-abdominal fluid collections. In this case, the underlying IBD is the cause, and this patient's medical treatment of underlying Crohn's disease should be optimized. Factors that can impair the fistula closure include the presence of foreign body, prior radiation exposure, undrained or untreated intra-abdominal infections, malignancy as the cause of fistula, distal intestinal obstruction or immunosuppression. In any patient's population with or without IBD, principles of managing a new ECF includes sepsis control, nutrition, fluids, electrolytes, and defining the anatomy and the cause of fistula. So basically, this is an enterocutaneous fistula. So this was the correct answer. Ruling out the other options what are given. So it is not recommended to take the patient to the OR urgently. The majority of enterocutaneous fistulas will heal on their own, and if needed, surgery should be performed in a delayed manner. So the first option was incorrect. Incision and drainage is not indicated needed in this, as no drainable fluid collection in the abdominal wall on CT scan. They have clear given the findings of the CT scan in the question that there was no collection. Okay, so this option is ruled out. Percutaneous jejunostomy tube would not be appropriate before fully defining the anatomy of the fistula. In this case, neither upper GI endoscopy nor colonoscopy would be beneficial, as we suspect this fistula to be located in the small bowel, and there are more effective methods of localization that better depict this small bowel. Okay, so broad spectrum antibiotics, fluids, electrolytes, this would be the correct option in this question. Okay, so one more thing I just want to give a tip regarding this is, not always you can find that only one option is correct. Maybe more than one option may be correct in the question. It is the best out of the two which you have to choose. Sometimes it happens you feel that no, this should have been correct, but it's up to the EDIC examiners. Like the umpire's decision is always final. So the EDIC examiners define which option has been correct, and mark will be given only for that. Okay, so don't worry. So again, a large question. So one tip more I want to give regarding this is, in EDIC exam, there are 100 questions, 3 hours. They specifically put this large questions, big history. Out of this big history, only few relevant points would be relevant, which would define the answer. So try to read the questions quickly. Make it a practice. Even now in routine practice, don't go to read the question slowly, because it has two disadvantages. First, it will waste your lot of time. Second, if you start reading slowly the question till you read the end of the question, you will forget exactly how you have started in the question and what were the points in that. See, I'll just show you how to read them and quickly grab the points so that you'll be able to reach the answer. This will save you a lot of time. Okay, like this is a 38-year-old male presents with bout of hematemesis 400 ml, bright red color in blood in ER, tachycardic, hypotensive, large bore IV cannulas obtained, 2 units of PRBC given, intubated for airway protection, admitted to the ICU. On the chart review, he is found to have significant alcohol abuse, several admissions for alcoholic pancreatitis, LFT and coagulation parameters normal, MRI, abdomen and liver biopsy, no evidence of cirrhosis, started on IV PPI and IV octreotide, USG shows no ascites, subsequently undergoes uh, EGD, which demonstrates oozing gastric varices that were sclerosed and cyanoacrylate, and EUS shows the thrombosis of splenic vein and calcification of pancreas. He remains hemodynamically stable, extubated. 6 hours later, he has another large volume hematemesis, becomes hypotensive, receives 3 additional units of PRBC. It stabilizes his BP. What is the next best step? Okay, so I'm not trying to say that you will be expert in this, but you need to try to read these big questions quickly. You just try to grasp exactly what are the relevant points in this question so that you don't waste the time. Okay, so the options here are tips, nadolol, continue massive transfusion protocol, splenectomy, or catheter directed TPA for splenic vein. Yeah, so it's a very typical case. Second bleed, stabilized with PRBC. What would be your next best step in this question? Okay, you can answer in the chat box. You regularly get such patients in the ICU, very typical. A, tips someone has answered. Yeah, any more want to attempt? Just go for it. Yeah. This is a mock exam type. A, even if you're wrong, no problem. A, most of your answered it at tips, but let's see what the correct option is D. D was splenectomy. Why should we go for splenectomy in this patient? Okay, let's see the explanation. The patient has a history of significant chronic pancreatitis, which carries 8% risk of splenic vein thrombosis. The splenic vein thrombosis can lead to a left-sided portal hypertension. The majority of patients with splenic vein thrombosis have no gastrointestinal bleeding, and splenectomy is no longer considered the ideal treatment in asymptomatic patients. Okay. Patients typically have normal liver functions, no signs of cirrhosis. Management includes EGD for diagnosis and management with banding and sclerotherapy. However, in the acutely bleeding patient who has failed the endoscopic management, splenectomy is the ideal choice to control the gastric variceal bleeding. That is why the tips and other were not the correct answer. The correct answer was splenectomy because he had failed his endoscopic management. That is why he should go for splenectomy. Ruling out other options like nadolol is useful to decrease the portal pressure for chronic management, but not useful in acutely bleeding patient. Tips will not decrease the portal pressure within the splenic vein as the obstruction is proximal to the portal vein. So tips was not an option in this. Patient has now stabilized after receiving 2 units of PRBC. Thus, ongoing massive transfusion protocol would not have been useful in this patient. And last one, TPA is currently not indicated for portal vein thrombosis. So splenectomy was the correct answer in this because he had failed the endoscopic management and there was a rebleed. If it would have been a first one, then splenectomy would not have been an answer. Okay. Next, we move forward. Just one. And now this is a 55-year-old female admitted to surgical ICU with severe abdominal pain, nausea, vomiting, diarrhea for last 3 days. Vitals are heart rate 122, BP 100/50, temperature 102. On examination, the abdomen is diffusely tender and voluntary guarding. Labs results are notable for leukocytosis of 18,000 and hypokalemia. The thorough medical history is significant for recent diagnosis of ulcerative colitis treated with sulfasalazine and recent UTI of which she completed 7 days course of ciproflox. CT abdomen and pelvis performed demonstrate significantly dilated colon up to 6 centimeter with diffuse colonic wall thickening with patent vasculature. What additional testing is required before full medical management can be initiated? So the options are CT angiography of mesenteric vessels, colonoscopy with biopsies, Clostridium difficile stool test, serum CMV test, and barium enema. One of very favorite topics of EDIC 1 examiners. You will get 1 or 2 questions on this topic, and lot of clues have been given for this diagnosis in the question itself. If you go through many clues have been given regarding the diagnosis, but just read the last line. What they want is the what additional testing is required before full medical management can be initiated. What test you need to do in this? Yeah, anybody wants to answer, they can just put in the chat box. So you have to be very specific in this. Okay, let's see what the answer is. Answer is C. It is Clostridium difficile stool test is to be performed in this patient. Why? This is a very typical case of toxic megacolon. They have given multiple clues regarding that. Okay, so this patient has finding concerning for toxic megacolon based upon the following criteria. There are following criteria. There is a radiological evidence of colonic distension plus any 3 of the following: fever, heart rate more than 120, neutrophilic leukocytosis, or anemia, plus at least 1 of the following: dehydration, altered sensorium, electrolyte disturbances, and hypotension. So this is a very typical case. In contrast to ulcerative colitis, where inflammation is limited to the mucosa, the toxic megacolon is characterized by extension of severe inflammation to the smooth muscle layer, which is thought to lead to colonic distension. Although the toxic megacolon is most commonly recognized as a complication of IBD, it can also occur with infectious and ischemic colitis. Toxic megacolon most commonly occurs through the first several months after diagnosis of IBD and not infrequently in the first manifestation of the disease. Okay. IBD is also a risk factor for C. difficile colitis, and so is her recent antibiotic. Have you seen the patient was on ciprofloxacin? So you need to do the C. difficile test to rule out this. Okay. Medical management for IBD versus C. difficile differs with the choice of antibiotics and use of corticosteroids. Steroids have not been found to increase the risk of colonic perforation. However, they will significantly surpass the immune system response of infectious colitis such as CMV, amoebic, or bacterial. Okay. Last, this patient has no prior history of immunosuppression. The CMV is unlikely, and the diagnosis of CMV colitis often requires endoscopic biopsies, which are too risky. Barium enemas to rule out distal obstruction are also high risk for perforation and should be avoided if possible. Okay, the next test in this would be to just do C. difficile toxin to rule out the Clostridium difficile infection in this patient. So Clostridium difficile, you need to be very clear. You need to read it thoroughly. Very important EDIC 1 topic. Recently, the guidelines have changed regarding the treatment of C. difficile. The recent guidelines have come in 2021-22. You need to be thorough regarding that. Because what I want to say is we have got lots of infective patients in our ICUs in India and Southeast Asia. But in UK here, C. difficile infections are very common. So every patient in my ICU who has got a diarrhea, we have to send a C. difficile, and many comes positive. In India, what we see is we rarely get positive C. difficile infections, and we are not aware of this. But here it's very common, and it's a very favorite topic of EDIC 1 examiner. So be thorough with this topic, okay? Next, this is a 53-year-old male with a past medical history, significant of alcoholic cirrhosis complicated with esophageal varices, presented to the ICU with hypoxia. He has noticed dyspnea on exertion that have been worsening over several months and complaints of platypnea. Breath sounds are clear, chest radiograph is normal, CT contrast negative for pulmonary embolism. Which of the following is the most definitive treatment option for this disease? Okay, so read carefully. They want the most definitive treatment, not the next step or the investigation. Okay, broad spectrum antibiotics, therapeutic paracentesis, nebulized bronchodilators, listing for liver transplantation, or bronchoscopy. Yeah, you can answer in the chat box. The question, read very carefully. Most definitive treatment for this. If you know the diagnosis, very typical clue is given in just one word. If you see that word, you'll get the answer. D. Someone has answered B. Any more wants to take this? D. Yeah, good. You should be able to answer. See, most definitive treatment for this is liver transplant. That is this is a very typical case of hepatopulmonary syndrome, and the clue was given in the fourth line. Platypnea. Platypnea is very typical of this uh, hepatopulmonary syndrome, which we see. So it was hepatopulmonary syndrome. The definitive treatment for it is liver transplant. Okay, I'll not go deep into the explanation. You'll get all this PPT and you can read that, because I don't think we have much time. It's already more than 45 minutes. I have just completed only 7 MCQs. Is that okay? Okay, you can read afterwards the explanation. I'll just not go reading out whole of the explanation. This will waste a lot of time. Okay, I want to try as and cover as many MCQs and give you more tips regarding the exam. In the last 5 minutes, I also want to give you some books and the tips how to pass in the EDIC exam. Okay, so we should be a bit quick. Is that okay? Should we move forward? Or you want me to read all the explanation of each MCQ? Should I move forward? So, question number 8, this is a 63-year-old male in the ICU waiting to be listed for liver transplantation. He becomes increasingly agitated and combative. His WBC count is 8,200, sodium 132, potassium 3.1, creatinine 0.9, blood urea nitrogen 15. CT reveals mild cerebral edema with no bleed or focal abnormality. He is receiving lactulose and having bowel movements 3 times daily. Which of the following is the most likely to improve his agitation? Intermittent midazolam, bisacodyl suppositories, soft restraints, broad spectrum antibiotics, or potassium repletion. So this patient is agitated. If you know why he is getting agitated and combative and what is going to improve his agitation, you get such complicated MCQs. E, someone has answered. Yeah. Anyone else? Anyone else wants to attempt this? D, broad spectrum antibiotics. Okay, let's see what the correct answer. At this point, one more thing. Someone has answered. You want to give midazolam for his agitation? You try to find the diagnosis. What exactly? He's listed for liver transplantation. What can be the cause of agitation and combative in such a patient? Okay, we'll see the answer. Just one more tip I want to give at this time is, while reading the MCQs and going for the answers, when you read the whole MCQ from starting till end, and then you try to find out the clues which are given in the question. Okay, one of the theories, few of them, what people do is what I also used to do to practice for EDIC 1. I don't say everybody should do this. What you can do is just read the last line, what exactly is the question of the MCQ, and then read the complete MCQ. How it will help you is, you know exactly the clues what you want from the question to answer. Like in this question, if you would have directly gone for the last line of the question, which of the following is most likely to improve his agitation? You know what the question is. Then you read the whole story which has been given in the question, and just grasp the exact clues what are being given in the question. Are you able to understand what I'm trying to say? Few of the candidates use these tricks to solve the MCQs. They are successful also. I don't say everybody should do this, but it can be successful. You can try for that. Like, you read the last line, which of the following is the most likely to improve agitation? And then read the whole question so that you know what exactly you're searching, because there are big questions in EDIC. They waste lot of time, lot of story will be given which will be irrelevant, so you know exactly where you need to concentrate. Okay, let's go for the answer in this. Everybody has answered. So this is a very typical case of hepatic encephalopathy. And hepatic encephalopathy is precipitated by hypokalemia. So you need to replace the potassium. That is very important. Okay. So let's see. This is a patient of hepatic encephalopathy. Around 30 to 40% of patients with cirrhosis will at some point have hepatic encaph. It is precipitated by a number of factors such as infection, constipation, GI bleed, electrolyte disturbances. Identifying, treating the precipitating factor is an important component of the treatment. Hypokalemia increases the production of ammonia within the kidney through an effect mediated by changes in the pH within the renal tubule cells. So hypokalemia is very detrimental in patients of hepatic encephalopathy. You need to treat it immediately. So the answer here was potassium replacement is to be given in this case of hepatic encaph. Other options I'll not go. This is the correct answer. Okay. Next, we move forward. Now, this is a 35-year-old woman evaluated in the ER for fever, epigastric abdominal pain, nausea, worsened during the course of 12 hours. Denies any medical history. Father has got gallstones. Temperature is 38.4, heart rate 115, BP is 90/60, respiratory rate 19, saturation 93% on 2 liters nasal cannula. After the blood is drawn from lab testing, she is given 4 liters of RL over 4 hours. She is also given IV hydromorphone 1 milligram for pain, vancomycin 1 gram, cefepime 2 gram for fever. Abdominal ultrasound is equivocal for gallbladder thickening, but shows pericholecystatic fluid and dilated pancreatic duct. Pancreas appear inflamed, but no necrosis or cyst is noted. Critical care service is consulted for severe pancreatitis. Vital signs after 4 liters of crystalloid, his temperature is 38.9, heart rate 109, BP comes up to 110/75. Respiratory rate is 22 and saturation is 91% on 2 liters of nasal cannula. Labs, the BUN is 45, creat 1, AST 235, ALT 129, amylase 2023, bilirubin 2.9, lipase 4300, WBC 14,000, hemoglobin 15.5, hematocrit 47, platelet 4,50,000, lactate 1. Which of the following principles apply to the patient's management? Lots of clues given in the question. Okay, they're asking principle which can be applied for management of the patient. First is immediate CT with contrast will provide the most prognostic information. Empiric antibiotics should be continued because they will decrease her risk of death. Initially, she should be given the bowel rest because enteral feeding may worsen the prognosis. Chest radiograph may be helpful in determining her disease predicted mortality at 30 days. And further IV fluids will decrease her risk of death. So the diagnosis is very clear with the clues given in the MCQ. It's very typical case of pancreatitis, raised amylase, raised lipase, very typical. So just concentrate on the last line. Which principle applies for this patient's management? Okay, you can answer in the chat box if you have answered A, if you have answered B. A again, pancreatitis. Again, one of the favorite topics of EDIC. When you will get few MCQs regarding this. The correct answer here is D. D is Chest radiograph may be helpful in determining her disease predicted mortality at 30 days. Why? Why chest radiograph is so important to do on admission to a patient of pancreatitis? No, CT severity index is the later thing. Why? Regarding the prognosis can be defined on admission by what is most important. The question is based on the bicep scoring system. So scoring systems in pancreatitis is very important. You should be thorough with each and everything. You may most likely get at least one question on this. So why D is the correct answer. The most widely used scoring system for acute pancreatitis is Apache 2, but it's cumbersome. We don't usually use. Bedside severity index for severity of acute pancreatitis. The bicep scoring system is validated and easier to calculate. It consists of blood urea nitrogen greater than 25, impaired mental status, SIRS response, and pleural effusion. The last P, if you see, it's pleural effusion. It's one of the part. Is the slide visible? This is based on basically the bicep scoring system, and the P is the pleural effusion, which can be diagnosed on just a bedside chest X-ray. And a score of 3 or more shows significant increase in mortality in patient with acute pancreatitis. Presence of pleural effusion in this patient takes her score to 2 to 3, with increases the 30-day mortality. Chest radiograph also can show the presence of pneumonia and ARDS. It completes the clinical picture. Okay. So very, very basic, the bicep score on which this question was based. So X-ray done shows pleural effusion, and that will predict the 30-day mortality. Okay. Rest options, we rule out. The explanation has been given. We will not go for that. This is the correct answer. Okay. Moving forward, this is management of severe acute pancreatitis update, which is given in Digestion. Very nice article. You can find this on net. You can go for it. It's very nicely given. Pancreatitis is one of the favorite topics, like Clostridium difficile infection, C. difficile. You should be thorough with that. Okay. Then there is a World Journal of Emergency Surgery has given these guidelines for management of severe acute pancreatitis. You can read these very nice guidelines. Okay. You'll get all these articles on it. Now, this is a question number 10. This is a 42-year-old woman, 2-week history of nausea, vomiting. Just one minute. She had bariatric surgery 2 months ago. Reports generalized weakness, fatigue, confusion, weakness of lower extremities associated with numbness in both hands and feet, and blurry vision. Physical examination shows sinus tachycardia, nystagmus, peripheral neuropathy, muscle weakness, decreased reflexes. Most appropriate next step is the IV administration of systemic steroids, antibiotics, thiamine, or immunoglobulins. If you can guess the diagnosis, very typical 2 symptoms have been given, which will take you to the diagnosis: nausea, vomiting, bariatric surgery, nystagmus, peripheral neuropathy, muscle weakness, decreased reflexes. If you know the diagnosis, then you can answer what is the treatment of it. Yeah, you can answer in the chat box. Just go for it. Okay, let's see what the correct. It's C. C is what? Thiamine, because this is a very typical case of thiamine deficiency. Okay, so thiamine is a raise, and mostly deficiency is most caused by depletion of B1 stores. People may become deficient in thiamine by not ingesting enough B1 in diet and through the body's excess use. The latter may result from hyperthyroidism, pregnancy, lactation, fever. Thiamine deficiency can occur after a bariatric surgery. It's very common. With nervous system involvement, it is called as a dry beriberi. Neurological findings can be peripheral neuropathy, characterized by symmetrical impairment of sensory, motor, and reflex functions of the extremities, especially in the distal lower extremities. The peripheral neuropathy in thiamine deficiency may also present with subacute motor axonal neuropathy mimicking GBS. Another presentation of neurological involvement is Wernicke's encephalopathy, in which an orderly sequence of symptoms include vomiting, nystagmus, palsies of the eye movement, fever, ataxia, progressive mental impairment leading to Korkhoff syndrome. So prognosis is good since the condition mostly responds to thiamine. So very typical B1 deficiency, Wernicke's encephalopathy was there in this patient having nystagmus, which was given in the options. So the replacement needs to be done is B1. Okay, thiamine was the answer in this question. Next, these are the 10 questions of type A, where this is a single answer. Next is type K. These are the multiple options. So in this MCQs, it's not always fixed. It can be like 70-30, it can be 60-40, but the type K questions can never be more than 50%. This is what the EDIC says. One tip regarding solving this type K questions, don't consider this type K question as a single question. The 4 options which are given, see, type A, there will be 5 options. Type K, there will be 4 options. Consider each option as a single MCQ. You're understanding what I'm trying to say? The 4 options, each one would be true or false. You have to answer, and each one will consider it as a single MCQ. The marking system is also quite what I can say harsh in this, and most of the people who fail in EDIC 1 exam, if they are not able to solve this type K questions properly. See, in type A, if you rule out the other ones, you'll be able to reach the diagnosis or the correct answer. In type K, each and every line, the option is like a single MCQ for you. And the marking system is such that if you answer all the 4 correctly, true or false, you'll get 1 mark. If you answer 3 correctly, you'll get half mark. If you answer 2 correctly or 1 correctly or 0, you don't get any marks. So it's quite harsh type of marking system in this. And the lesser you get the type K question, the more chances of you are passing the EDIC exam. Usually it was 70-30, but sometimes they put 60-40, sometimes they even put more type K questions. Okay, so it's not predicted and it's not fixed. I think it's already time, it's 1 hour. I don't think I'll be able to cover this type K section in this lecture. I think 1 hour is more extending too much. You'll not be able to grasp anything. I don't think more than 1 hour your mind will be able to concentrate on that. I think I can take a next time any other class, or should I continue? It will take more time. I don't think you'll be able to grasp. What do you say? Should I stop here for today? Next time I can cover this type K part.
Yes, sir.
Huh? What do you say? Or should I continue now? I don't feel it's appropriate to continue. No? You will not be able to concentrate more than 1 hour. I think I'll take this type K part next time. Only 5 more minutes I wanted to tell you regarding this exam marks distribution topic wise. Most of you who appear for EDIC 1 exam don't know how the distribution of the mark is. If you go on the ESICM site in the education section, they have clear cut given a very nice EDIC brochure. In the EDIC brochure, they have defined each and everything, how the exam would be, how is the marking system, how the MCQs are selected, who are the people who set the MCQs, how many repeat questions are expected. After solving the exam, when the result will come, how do they exactly plot the percentiles. Even they have given that few of the MCQs which are controversial, they just rule them out and then calculate your score. So I think before going for the exam, it's very, very important what I say. Before playing a game, I'm a big fan of cricket. What I say my students is, you should know the ground and the pitch prior to playing any game. So till you know how exactly the exam is going to be, you'll not be able to pass. So I would recommend everybody to go into the ESICM site, download the EDIC1 brochure and go through it thoroughly, so that you're very much aware how the questions are. Few slide, just one slide I can show you. This is from that brochure. So they have given a blueprint how exactly and what percentage of weightage of marks would be on different systems and different things. So like disease management, 50% marks will be there, and the MCQs will come exactly in this distribution. It's not that some questions will be from that here and there. It will be, the distribution will be almost like this. Like practical procedures, 10% marks, patient general care, 10% marks. So they divide this like this, and exactly they prepare the question paper like this. Like this was the score which is given when you will receive your answer sheet. This is how the result will come to you. Like cardiovascular disorders, the maximum score was 9, and how much did you score in that? Renal and genitourinary, 3 questions were there. How much did you score? What I want to focus you on, this is the last 3 parts. The last one part, patient general care, 13 was the maximum score. So much MCQs on patient general score. Organ system support, 7 in organ system support. So these are the side topics which you usually don't cover. You directly go for cardiovascular, neurology, GI, respiratory, but much focus is all the organ support system, perioperative care, practical procedures, and patient general care, which usually most of the students neglect this question. The scoring systems, very, very important. Many MCQs you will get on scoring systems in EDIC exam. So I would recommend you to just don't neglect those topics and try to read those topics for EDIC. Last, I would like to inform you regarding some EDIC1 preparatory material, what you can go through. So first one is this academic courses. When you go into the ESICM site, you log into the education section, it will take you to some courses, the ACE courses. ACE courses, there are multiple courses defined which describe everything, like acute ischemic stroke is there, AKI is there, ARDS is there. So all of them. After each course, it's very difficult to read the complete module. It is a very big modules which have been given. For EDIC1 exam, it's difficult. If you go on reading these modules, you will never be able to. What I recommend is just go to the last section of each module. They have given few MCQs in that. Like in few of the module, there may be 5 MCQs, few modules, there will be like 3 or 4 MCQs. When you solve those MCQs and submit it, they will give you the answers with explanation. They are very, very important. I would recommend every one of you should go through this MCQs. These are very important. And in my EDIC exam also, I saw that few of the MCQs have just come as it is from there. So I would recommend every one of you to read these modules. There are around 50 modules given in that, and each module, some have got 3 MCQs, 5 MCQs, not much, but they are very, very important. Okay. Then regarding few books, the Bible for EDIC1, which EDIC recommends, is Steve Bennington book. Both the editions, I think you should go through this. This should be the first book you should read. You'll not get the MCQs as it is now from this, but they have got lot of information, and this type of MCQs are the one you'll get. Okay. Both the editions I recommend you should go through that. Next is, this is a self-assessment adult multi-professional critical care. This is a SCCM book by Americans. So I'm showing you the 8th edition. Now the 9th edition has also come. It's available in the market. You can get that. Excellent book. Not much MCQs, but very, very important. And few of the MCQs come in the EDIC exam as it is from this book. So I would recommend, I don't say everybody should go for what I'm trying to say, but I would recommend this book to you. Okay. And the last I would recommend is this 1000 MCQ book. Very vast, topic wise, it has been given. It is sometimes difficult to complete this book. It's very, very vast, 1000 MCQs. But if you're completing the EDIC modules, you're thorough with the Steve Bennington, you're thorough with the CCM book, you can go to read this 1000 MCQs. But it's very vast. Okay. The questions are nice with the explanation topic wise and subtopic wise. If you can go through this all things, I think no one can stop you from clearing EDIC 1. Okay. And the last part is the Farz Academy is always there. The whole faculty, everybody here is to guide you, to take you through this EDIC complete journey. So anytime you have any doubts regarding the questions, regarding preparation, how to go about you, any silliest of the thing, you can just message the coordinators of FIRS, and we will be very happy to help you if we can in that. Okay. With this, I end my class. Thank you. Any doubts? Anything? Anyone wants to ask anything silliest of the question? Don't worry. You can just go for it. Even if not now, any day further, you have any questions which comes in your mind, you can just message the Farz Academy, and the faculty would be glad to answer if we can help you out with that. Okay, then I think I'll end my class with this, and I'll try to accommodate the type K questions in further class when I get time. The first people will definitely help you out to know prior when I'll be completing that. Okay.
Thank you, sir.
Okay. Thank you.
Thank you.